Dr. Mohamed Hashim, he is a respiratory registrar at Sunderland Royal Hospital, and he's going to give us a talk about the chronic steroid use in the COVID-19 era. Welcome, Dr. Mohamed Hashim. And I think, could you share your slide with us? Okay. Yeah, I think.
So we've been having technical issues, so I think Abdulazim is going to be sharing and kind of moving the slides forward.
All right, okay. Welcome.
Okay, so I'll make a start by, my name is Mohamed Hashim. I'm a final year respiratory registrar, currently working in Sunderland Hospital. I want to first of all start with thank you, May, for your nice talk, and we'll progress to the next session. So basically, to start with, I have no disclosures to mention, and I want to start by kind of giving an outline to what I'm going to be talking about today. So we're going to start by a quick introduction about corticosteroids, what are they, and mechanism of action. We're going to talk about a few uses and major side effects that we worry about. And then my line is respiratory, so we're going to talk about patients who are using steroids or in general immunosuppression, what we've been doing or what's the guidance to do for during this area or during COVID era. So start with corticosteroids. So they are man-made drugs that closely resemble cortisol, which is a kind of stress hormone produced naturally by the adrenal gland, and it's controlled by the pituitary gland as well. I'm not going to go into details, but it regulates kind of a number of physiological processes that are essential for life, which we'll talk about later. So next slide. You've got glucocorticoids and you've got mineralocorticoids, which basically are different. They work differently, but we're going to mainly be focusing on cortisol here. Next slide. So they have an effect on the immune system. And for that, they have been widely used worldwide, and it's estimated that it's kind of worth upwards of $10 billion per year. Next slide. So the mechanism of action, the drug basically diffuse passively through the cellular membrane, where it binds to intracellular receptors to kind of gain access to the nucleus, and its effect directly on the DNA sequences on the glucocorticoid responsive elements, the GREs. Next slide. So by doing that, it causes an anti-inflammatory effect, mainly by promoting, blocking promoter sites for pro-inflammation and promote anti-inflammatory gene products, and also inhibit synthesis of almost all inflammatory cytokines, and that's the main kind of way that it reduces inflammation. Next slide. It has an effect on different metabolism, carbohydrate, protein, fat, and water retention, which kind of explain a lot of the side effects profile that we have, which I'm not going to go into details as well. Next slide. It also affects on muscle as well, and blood vessel, and the CNS, and all that kind of explain the wide side effects. Yeah, next slide. So it has an anti-allergic action, and it suppresses all type of hypersensitivity reaction, and that's explained the use in all form of allergy. Also suppresses leukocytes and antigens going to the response to immunological injury. Immunosuppressive action, where it kind of suppresses the immune system by decreasing the circulating T cells and prevent release of interleukin-2. Next slide. That's just the same. So next as well. So again, this is just to kind of illustrate the negative feedback that you get, and to explain that to kind of dropping or stopping withdrawing the medication suddenly would cause kind of an adrenal crisis, because you're not producing the cortisol or the steroids that you need. So kind of this is just to illustrate the negative feedback. Next slide. So we can normally classify them on different ways, but the mechanism of action, the relative activity, you've got short-acting like hydrocortisone, normally given IV for when you want to kind of have rapid access. So you've got your sick patients who you need, who, for example, are in adrenal crisis, you need to get the steroids in quickly. You've got intermediate action that would work for 12 hours, maybe 36 hours, and that's the most common, the prednisolone and the methylpred. And you've got the long-acting dexamethasone, which basically you give for kind of for the longer action. Next slide. Potency as well. So there's difference between drugs. Kind of the standard is prednisolone that we use, and you've got different preparations and different strength, and which you have to kind of use for different processes. Yeah. Next slide. Now this is the uses. Now this is a very short list of uses for steroid. You've got every system in your body needs steroid, and this is just part of it. And then we'll go into a bit more details next. Side effects. So the adverse effects of corticoids are both dose and duration dependent. So you've got the effects that happen quite quickly after just a dose, but the majority of them happens with long-term use. They also affect different organs differently, which we'll come to more details now. And it could be a range. It could be something as simple, kind of not simple, but a bit displeasing, and it could be life-threatening. So it's a wide variety of side effects used for differently. Next slide. So we're going to talk about side effects. We talked about different systems affect every single system in your body, giving you different side effects. But the most important thing, which was on the just go to this, yeah, this one. So the hyperpituitary adrenal axis suppression, and that's quite important because stopping abruptly or kind of rapid withdrawal could cause an adrenal crisis due to adrenal insufficiency because of the negative feedback that you get. So that's why it's quite important to taper the drugs when you're stopping them. And also tapering the drugs, you have to factor in the reason that you started the drug for. Some disease processes, when you stop this, the steroids, it can relapse the disease, come back quickly. So that's why you will need a longer wean rather than stop, which makes it difficult during COVID times because this affects, as we see, in your immunity, and it affects and makes you more susceptible. So we're going to talk about, next slide, please. So we talked about this and in terms of the immune system effect and how it affects both acquired and innate immunity, and it causes kind of increase the risk of not just bacterial, even viral and fungal infections. And also another big sign is manifestation of infection. So because you're not getting the because of the inhibition of the cytokine release, it could be you will not kind of see the signs of infection, delaying the diagnosis of infection, which can be dangerous. Next slide. So I'm going to be talking the next few slides about different diseases, especially in respiratory, and what's the guidance for what to do in COVID times. Nice guidance have kind of have issued a number of guidance to what to do with these patients. So in terms of asthma or severe asthma, so patients with asthma need to be shielding during this time because picking up the drug, they are at a higher risk. But the question is, are steroids, what should we do with their steroids, for example? So with asthma, they take two forms of steroids, could take two forms of steroid. The main treatment is inhaled corticosteroid, which is essential for patients with asthma and shouldn't miss. And the second is oral corticosteroids for patients who've been kind of brittle asthmatics who we just can't wean them off. And also you've got the acute exacerbations of asthma. So nice guidance basically is that inhaled corticosteroids there's no evidence that's increased the risk of getting COVID, and it's quite essential, so should not be stopped. You can continue inhaled corticosteroid as usual. In terms of the maintenance corticosteroid, it's going to be a patient-by-patient decision, but if it's prescribed, that means the patient needs it, and you need to continue. But maybe you will reassess the patient and see if you can slowly wean them off it. If not, then they need it. You need to continue with them. In acute exacerbations, every patient, when they have an acute exacerbation, should have an asthma action plan that tells them what to start, how to start it, when to seek help. That should be followed as normal. Next slide. Some patients with asthma are on the new biological treatment, which is the omalizumab, which is the anti-IgE, and mepolizumab. Currently, we have no evidence that these suppress immunity, so they should be taking them as usual. But these drugs are given IV, they need to come to hospital, and I think that's the risk that we need to kind of weigh in. Can we, for most of these patients who are on these are kind of young patients, can we give them and can they give it at home on their own? You need to be routine checked. So I think for most of these patients, you need to kind of think about monitoring and how you're going to monitor them routinely. So that's the tricky situation that comes in. But in terms of the drug itself, there's no effect on immunity and they should be continuing them. Next slide. In terms of COPD patients, again, they would have inhaled corticosteroid and they would have oral steroid. So we said that before, inhaled corticosteroid, there's no evidence that increases the risk. Long-term steroid are mainly just like asthma patients. If they need to take them, they need, because not taking the drug could be dangerous. Stopping the drug abruptly is we shouldn't do. You should always taper it down. One thing to mention in COPD that not all COPD patients need steroid. There is some evidence to suggest that in COPD patients, inhaled corticosteroid increase the risk of bacterial pneumonia. So that decision need to be kind of looked into now. That shouldn't be the only factor to not give somebody inhaled corticosteroid, but it should kind of be looked into as a whole picture. So normally we preserve inhaled corticosteroid in COPD patients, for patients who exacerbate frequently, have a higher level of eosinophils in their blood. Those are the patients that we know benefit from inhaled corticosteroid. And it's always a risk and benefit that we just kind of have to think about. In terms of another factor to factor in when the patient comes in is to kind of see what symptoms they've got. Now, if they've got symptoms of COVID without any sign or symptoms of exacerbation of the COPD, you shouldn't be starting steroids for them, but you should closely monitor them. So exacerbations, they need steroids, so you give them steroids, but not all the time, not for every infection they get. Next slide. Smoking is another big factor, and there have been data to suggest that people who smoke do badly. So there is correlation with severity of COVID and death. So always, whenever you get a chance, advise people to stop smoking. Next slide. Interstitial lung disease is a big umbrella of many diseases and disease processes. You've got something like sarcoidosis, IPF, and many others. So it depends on the patient. There isn't kind of a one hat fit all here. You have to kind of weigh in a lot of factors. For starting a new drug, you need to see what's the patient clinical condition. Are they stable or not? If not, because starting immunosuppression increase the risk, so you need to think that carefully. Is there an alternative treatment? For example, in some situation, giving them steroid may be better than just giving them immunosuppression, and just see how they go with that. Monitoring is another thing, because they will need close monitoring. So if you can't monitor the patient, it's safer not to give the drug. So all this should be considered very carefully. For continuing the immunosuppression, again, you would have the same considerations. How can I monitor them? Is it safe to bring them to clinic to do their bloods and see how they go? Are they developing signs of infection? And all this is quite key in deciding whether to continue or not. So you need a specialist, multidisciplinary kind of decision really before you decide to start somebody during this time, because there is an increased risk. And also putting into fact, a big factor is how progressive the disease is. If it's a progressive disease, then you will need to start them on something. Next slide. So we talked about this. So sometimes maybe giving them steroids would be helpful. A category of patients where they IPF patients, the idiopathic pulmonary fibrosis, they have antifibrotic therapy, which is pirfenidone and nintedanib. Now, currently we have no evidence that increased the risk of COVID, but again, we have the problem of monitoring. These drugs could have quite serious side effects, and they need to be monitored. So if you can't monitor the drug, it's safer not to give. Next slide. I'm going to finally talk about transplant recipients during COVID, or if you're suspecting COVID, because patients who had a lung transplant or any organ transplant would have kind of three forms of depending on how far the transplant was. They would have steroid, they could have a antiproliferative agents like azathioprine or MMF, or they would have a calcineurin inhibitor like tacrolimus or sirolimus. So if you can afford to stop the antiproliferative medication, the azathioprine, you would stop it until full recovery. Calcineurin inhibitors need to be decided by the team. So always discuss with the transplant team because these are quite key. You would try and reduce the dose as much as possible without having any symptoms of rejection. It has to be tailored to the patient, basically. There isn't anything to do that any kind of decision that you make. In terms of the steroid, it's not advised to increase the steroid. If you're stopping the others, you would just kind of hold the same. And then dexamethasone help here, especially if you got RDS as decided by the recovery trial. Thank you very much. Any questions?
Thank you, Dr.
Thank you very much, Dr. Mohamed, for the nice presentation. Now, I would like to ask the panel members. Dr. Maher, do you have any comments? Is Dr. Maher with us?
Yeah, right. Question now. Sorry, few questions if you don't mind, Mohamed. Okay.
Mm-hmm.
All right. One of the question people who are chronic, they're using steroid long term, right? And there are quite a few of them, really. Do you consider bone protection in them, or no? This is the first question. And if you consider that, what is the right medication and dose? And this will be for the benefit of the audience, especially back home, okay? The other question, I don't know whether you have noticed that or not, during this COVID epidemic, I noticed something. I noticed people who are in immunosuppression, they do better than people who are not immunosuppressed. I have seen quite a few patients, and they recovered more quicker. And I don't think we lost any patient in our hospital, at least, who was immunosuppressed. Do you think this is due to suppression of the cytokine storms in COVID, or do you have any data about it, or or have you read any because I don't know myself, and this is why I'm just asking this question. If you have any, if you have read something in a new article or any research about that. Okay, sorry, these are two questions.
So in terms of chronic steroid use, and one of the things that kind of we didn't go through, which is the effects on the bone and thinning of the bone, and the risk of osteoporosis. Anyone who's using steroids for longer term at an increase at a moderate or intermediate dose should be on bone protection. And we normally kind of on a yearly basis check their do DEXA scans and check for the bone, and then basically they would be on anticoagulation and they will be on bone protection. Now, to what it is, it depends on the level. They could be on calcium supplement or an antiphospholipid. It depends on the DEXA scan, what it shows. But yes, they need to be, and that need to be kind of considered, especially if they develop fractures or if they have anything of the bones on x-rays. In terms of the question on immunosuppression, we have noticed that, but I haven't seen any data, to be honest. Especially even the transplant patient, we expected to kind of see a lot of them, but we haven't seen a lot of people who've been immunosuppressed. Now, what's the cause could be related to the inhibition of the immune system by the anti-inflammatory effects. It could be, but we don't know. I haven't got any data, to be honest, but it is something that we've noted. Other people with chronic COPD, they do badly. We've seen that. We've seen a lot of people die in our hospital with comorbidities, COPD, cardiovascular. But immunosuppression in well patients, yes, I agree. We've seen that they do well. And transplant patients, we haven't seen many. But I haven't seen any transplant patient or any immunosuppressed patient in my hospital. But that's the observation that we've kind of seen. But I haven't got any data, I'm afraid.
Thank you. Thank you.
Thank you. And Dr. Maher, I think that was a really good question, because that's the question that was on my mind too, was regarding the interaction of immunosuppressants, chronic immunosuppressants. Because we know in infection, patients die because of two main reasons: either overwhelming infection, so things like Staphylococcus infection that just overwhelms the body and causes patients to die and deteriorate, or, as you mentioned, the body's immune response to the infection, or we call it hyper-responsiveness. So as you mentioned, the cytokine storm, those are the patients you tend to see perhaps in intensive care. And it's not the infection that's overwhelming them, it's their own response to infection. And I think what you said is really on point, because the results of the recovery trial showing that dexamethasone in patients who are in ITU who deteriorated, that they benefit, I think that's really supports that the hypothesis that perhaps the COVID infection is not it's not a serious infection as per se. It's more the risk is of your own body's reaction to the infection. Is that something that you would
really, first of all, thank you for that. But we need also to impress here, to stress that, but obviously not that people who need the dexamethasone, there are certain category of the patients who need oxygen. I don't want people in Sudan or somewhere just to go and just stack those drugs, dexamethasone at home and things like that. So if Mohammed could tell or educate us about who needs this from the recovery trial, who needed that, or Ahmed as well, both of you, one of you, because who needs this dexamethasone treatment, which type of patient really, because I'm just under the impression people are going to start stacking those drugs at home, and I don't know, most probably this will make the drug more scarce in the market.
Yeah, so you're right there. So I think that is kind of dangerous, and one of the things that we mentioned is steroids have side effects, and you can't keep using them for a long time because you would have the side effects. The recovery trial basically showed that, as you mentioned, people who need oxygen, people who have respiratory, the respiratory system has been affected, who recover from them, and it's short courses. It's a 10-day course of dexamethasone that helps. So not everyone who has COVID needs it. It's the key here is, have they been needing oxygen or not? Have there been element of hypoxia? And taking, so somewhere like Sudan, if you use dexamethasone and everyone kind of stacks it at home, you will be scarce in the market, as you said, and then people who actually need it will not find it. So I think that's really key point here, is not everyone needs dexamethasone. It's patients who need hypoxia, so you need to be in hospital for that, and it's a short course, 10 days, and that helps. Does anyone want to add anything?
Thank you very much, Dr. Hashim. I wanted to ask a question regarding patients on using chronic steroids. If they were to get COVID and they had a serious infection, what do you advise them to do regarding their steroids doses?
So if they have CNS, can you repeat the question again? So
a patient who's on chronic steroids,
yeah,
who then develops COVID infection, and
yeah,
what do they do about their steroids?
So the advice is to keep the steroid. It depends on the patient, because then with the negative feedback that we talked about, your body basically can't handle the stress. So some patients who, especially been on kind of higher doses of steroid for longer term, they might need to increase the dose of steroid rather than drop it, because your body is under attack. Your body is dealing with the stress. And if you are not taking steroids, your body normally produces more steroid to deal with it. But because of the negative feedback that you get from the chronic use, you lose that. So that the idea is maybe increase the dose of steroid rather than drop, depending on how sick the patient is, basically. That's the advice for acute patients.
I think there's a question here from the audiences. The question says, is the inhaled steroids, in addition to dexamethasone, has any benefit? I presume that if the patient is already on steroid use, maybe in chronic steroid, yes. Yeah.
So there's no evidence. There's no evidence to start inhaled steroid if the patient is not on inhaled steroid. If I understand the question correctly, if you're not on inhaled steroid and you have COVID, don't start inhaled steroid. But if you're on them, you don't have any increased risk, so you should continue them, basically. We haven't got any data that inhaled corticosteroid helps in COVID. If that's,
you don't mind, Thank you, Ahmed. Thank you, Mohammed, for this is fantastic presentation. It is really great talk, and did a lot of learning message, and we did learn a lot of things here. So the question from one of our senior cardiology consultant in Sudan, Dr. Mohamed Al-Badri, he just pointed to one of the Chinese series of the patient with heart transplant who continued on immunosuppressive medication during the COVID, and they got COVID anyway. So the observational data, this observational data showed that this patient, they did very well. So the question now, it is just like observational data on the small number of patients, or do we have any strong evidence on this?
That's the only thing I found. I couldn't find any other data, but just observational data from talking to people around us who deal with these patients is they actually do well. But I haven't got any data apart from the kind of very small studies. But as I said, we haven't got much data. We haven't got a large pool of transplant patients. We haven't got, it's all kind of new. So I'm not aware of anything else apart from that.
Thank you. Back to you, Hind.
Any further questions from the panel members or the audiences? I think there's a question here from one of the audiences. The question says, the use of steroid, I think the dexamethasone in patient with CT findings. I presume that this, if the patient has CT findings without symptoms, with mild symptoms.
Unless they're needing oxygen, we wouldn't advise them. We wouldn't advise them unless they need oxygen. They're unwell with hypoxia and need oxygen. I don't think it's there's any benefit of starting it.
Thank you. I had just one question for yourself and Dr. Maher Hamid. It's just mainly about sharing experiences. So have you seen cases where patients have been started on dexamethasone since the results of the recovery trial?
Personally, actually, I haven't. There's one patient who we started who went to ITU, but I haven't followed them up. Actually, that was quite recent. But that's only one patient, so I don't know what the outcome was. But actually, I'll go and look into that. I'm not sure other people, have they got experience with dexamethasone, especially coming through acute medicine?
I think I have seen quite a few, especially we have been involved in the recovery trial, and I think like what the result of the trial, I think they do well. Those people who needed the oxygen, people who did not need oxygen, it really did not affect their outcome really, because those are really very mild disease anyway, and they improve by themselves. They improve, but people who definitely needed oxygen or CPAP, and I've seen quite a few of them who improved remarkably. It's just like magic. So it works. Definitely it works.
Okay. Any further questions? Dr. Abdulazim, Dr. Ahmed?
Nothing from my side. I think that the question here on Zoom chat, just I tried to clarify exactly the question, but I can pass it to you, Mohammed, if you think. So the question, when you mention double dose of steroid, do you mean that stress dose on the patient with COVID-19 and COPD, or?
Yeah, so I'm talking about people who are on maintenance chronic patients, not somebody who needs steroids acutely. So acute patients, you just give them steroids as normal. I'm talking about people who've been using it for a long time, been on maintenance dose, because you need to increase the dose. But not everyone who needs steroids acutely, especially, you don't need to double the dose. You don't need to give them higher doses of steroid. You just give them the standard dose. It's the chronic patients, chronic users of steroid who are coming in acutely unwell. You need to think about increasing the dose of steroid. for them to help them deal with the stress that they're under.
I need to add to this. Definitely what Mohammed said, Dr. Mohammed saying that we have to stress on that. The rule of thumb, if somebody on chronic use of steroid, those people who have adrenal insufficiency because of the chronic use, it is a must. It is a must that when they come, we should at least increase the dose, not double the dose. Ideally, we should double the dose and then reduce it after they improve. But they must have, we must increase the dose of the steroids. We must. Thank you.
Right. Now, any further questions? Right. Okay. If there are no any further questions, I would like to thank Dr. Mohamed Hashim. Thank you very much for the fantastic presentation.